Talk Radio 790 KABC, the medical show with Dr. David Kipper and Peter Tilden. And you can, of course, participate in our conversation. Ask questions for Dr. Kipper, of Dr. Kipper at 800-222-KABC. I just called you Quipper. 800-222-KABC. See the importance of a good night's sleep, which I never get. I get punched. Do I get punchy and delirious often?
Yeah.
Okay, thanks for that.
Yeah.
Joining us now is a doctor who's going to talk to us about cancer treatments. Cancers are so prevalent in our society today because of environmental factors, genetic factors, and there are new advances as far as cancer treatment and cancer detection, correct?
Yes. This is Dr. Bagdasarian, who's an oncologist who's very, very well respected, has amazing credentials. And Dr. Bagdasarian, first of all, hello.
Yes, good morning. How are you?
How are you?
I'm very good, thank you.
No, I mean literally. Have you done checks on yourself and everything? How are you?
I'm very good.
Okay. By the way, I always wonder that. With a doctor who specializes in hematology and oncology,
yes.
Do you, the minute you suspect something, do you do tests?
Honestly, as they say, doctors are one of the worst patients.
Wow.
But however, as oncologists, yes. I mean, at times we get alarmed, especially in my early years and during my training process. If I felt a little lump in my neck or under my arm, typically it would be some reactive process to possible infection. We would jump the gun, and many of my mentors would laugh at me and tell me that.
Then you get your license and forget about it. Then you want to know about it. Dr. Bagdasarian, I know that you specialize in breast and colon cancer, and I have a couple specific questions, and then I'd love for you to expand on this.
Sure.
There's been a lot of information recently, studies showing that breast MRIs combined with mammograms are probably the best screening device for breast cancer. Can you comment on that?
Absolutely. The majority of our, especially our premenopausal women who have dense breasts, during their monthly cycles, the breasts or the glands generally are well maintained in the integrity of the glands, and there's a subset of women during their perimenopausal and even into their postmenopausal years that still will maintain the integrity of the glands, and hence at times lesions or tumors can be obscured where even the best mammograms, the digital mammograms, can miss. So it's now really the standard of care in this country to incorporate the use of both mammography and MRIs in such patients.
So Dr. Kipper has been talking about that a long time, that MRI is the way to go. Should that be the way to go for most people or all people, not just if you have dense breasts?
I believe that if you look at the majority of the postmenopausal women in their 60s and into their 70s, the only times that we would recommend, now this is, of course, there are specialized situations depending on the type of pathology or malignancy that is identified, such as lobular carcinoma, which tends to be missed on mammography.
Right.
But for the most part, if you look at the NCI and studies at the NCCN, as well as the American Society of Clinical Oncology guidelines, it's still generally recommended for women who are in their premenopausal and an individualized group of women who are in their postmenopausal phases that have dense breasts. For the most part, I think to utilize MRI across the board on everybody is on overkill.
Okay, not necessarily. That's good to know.
What breast cancers will you miss on a breast MRI?
On a breast MRI, generally there are lobular carcinomas, which are typically multifocal, meaning that it could occur in different quadrants of the same breast and involve the opposite breast, compared to the garden variety breast cancer, which is the ductal carcinomas, and that typically is seen in 80+% of breast cancer patients. Lobular carcinomas generally, when small, will not be visualized until it becomes a prominent sized lesion, something in the neighborhood of over a centimeter plus. For the most part, those can be missed. In early stages, they can be missed. So, for example, ductal carcinoma in situ, which is a precursor to developing invasive breast cancer, can be identified with a cluster of microcalcifications and trabeculations. These are changes that are pathognomic of that condition, which leads to a biopsy. the early stages of lobular carcinoma sometimes can be missed. So those are a small subset of patients.
Okay, I want to move south a little bit to the colon. What's the value of these virtual colonoscopies?
By the way, thanks for that trip. Went south of the border. I'm ready to put on a hat and.
That's right. Virtual colonoscopy is an interesting tool. However, it really is an extra step. So if the pathologic condition is identified, a patient will still have to go through a conventional endoscopic diagnostic approach in obtaining tissues.
You're talking insertion, basically.
That's right.
I got it.
Absolutely.
Hey, what about the virtual stuff? If a guy doesn't want to have a colonoscopy or endoscopy, is the other way, right? Down the throat?
Yes.
Can you do virtual? Is that as good?
In such individuals, if they're reluctant to proceed with the colonoscopy, it might be something to consider. Of course, if something is identified, he may have no choice in the matter in proceeding with the endoscopy.
But how high res is it? How good is it at catching stuff?
Initially, when the first virtual colonoscopic studies were published with the early technology, the resolution wasn't as good. And when they did comparative analyses, there was a subset that were missed. So
but today's decent?
Today's a little better, but it still doesn't really replace the.
So you should do. You should do. All right. Okay. But what percentage of the population think is reluctant to have that?
Can you say that again, sir?
What percentage of the population you think is reluctant to have the look-see in the
Well, I think there's a small subpopulation. These are patients that or individuals that are reluctant to go through mammography, Pap smears, and that's a small percentage. I think
it's 100%. We're right here, right? It's 100% in this studio.
No, but I have a medical alert bracelet that says if I'm out for any reason, from an accident, a car crash, do it then. Can I ask you another question? We started joking, and I usually, because there's tension when it comes to illness, especially cancer.
Yes.
There's tension. People have a certain fear. And you talked about, and I asked you about, do you check yourself, et cetera. When you hear about lumps in the neck and lumps under the breast, if people listening now, for everybody listening now, what should you feel? What is a worrisome lump as opposed to a non-worrisome lump when you feel? Because you started talking, and everybody in the room starts feeling their neck, under their neck and I was friendly with Brandon Tartikoff, who was the head of NBC, and he had a lymphoma twice, and eventually they had to do a bone marrow, and then he didn't make it after the last one. But he said to me, I just felt it felt like grapes, like under my throat area, and that was bingo. He was off and running at that point. What does it feel like? What is worrisome for somebody listening today that they should say, okay, that's not how that should feel. That's not what a lump should feel like.
So, one of the first places that you would identify or feel lumps is in the neck area. A lot of times these are treated with antibiotics in the assumption that this may be associated with an infection. Okay.
So how would I know that it's not that?
Yeah, well, a lot of times if the lymph nodes are very large, we're talking about 2 centimeters plus, the majority of those are pathologic. Reactive lymph nodes secondary to infections are typically less than 2 centimeters in size. So that's definitely 2 centimeters for those listening is about almost an inch in size. Okay?
So an inch. If I feel a lump that's about an inch, and it feels like a ball, it feels like a marble in there. Is that what you're?
It feels like a marble, and there's a chain of lymph nodes. Now, there are certain infections like mononucleosis at times that can reach to that size. But it's important to tie that in with other symptoms, sore throat, exudate or pus in the back of the throat, fevers, etc. may potentially.
I got it. I'm feeling it. How about the back of the neck?
In the back of the neck, the posterior cervical lymph node chains are generally, again, it can occur in both in the front and the back of the neck. It depends. If it's on both sides, you generally, it could be associated with viral infections. Again, I would piece that in with other symptoms.
But if it's on one, if it's just one on one side, then you got an issue, maybe.
Perhaps, and the size of that lymph node. If the patient or individual doesn't have any other symptoms, such as a sore throat, cough, etc., then that raises a red flag.
How big? How big would that be in the back of the neck? Again, like a marble?
Again, it can be anything over 2 centimeters or an inch in size. Should raise a red flag.
See, Dr. Kipper knows this stuff because he feels for this all the time. The average person listening is going, When's it a worry? When's it not? How about in your pits, if you don't mind me asking?
Well, then in the armpits, then we have to be concerned, and especially in a female. If there's something palpable, we always worry about the possibility of a breast tumor metastasizing or spreading to the axilla. And those lymph nodes, again, infection certainly can be possible, ingrown hair, a boil, etc. But if there's no findings, such findings, again, that would raise a red flag.
Size of a marble? Are we still talking the size of a marble again?
Size of a marble or larger, yes.
And is that hard or squishy or what?
The ones that we're really concerned about are the ones that are firm, tender. Sometimes the worst cases when they're fixed and there's a conglomerate or a fusion of these lymph nodes leading to a large palpable area. Those are typically identified sooner than later. A lot of individuals who are identified with such findings are generally in denial, and they're afraid that of what may be identified or feel that it's an infection, and etc.
And I think Dr. Bagdasarian, a good advice for people listening, which I think is get familiar with your system. Feel under your arms, feel your neck, because people do have lymphatic tissue and these lumps in general, and they more often are benign. So get to know what your anatomy is, and then when that changes, that's when you want to call a doctor.
And by the way, I should mention that you're with Dr. Bagdasarian is with Glendale Adventist. And not only, I'm looking at your credentials. Holy cow. When did you have time to sleep? President of the LA County Medical Association, chairman of the Cancer Committee at Glendale Adventist. Aside from that, an advisor and past president of the Armenian American Medical Society of California, and you're an oncology consultant for ABC, CBS, CNN. So you do a lot of this and alert people to what's going on. I just like to give tangible stuff, and I thank you for that. And I know you're involved in bone marrow transplantation, which has come a long way too, correct?
Yes, I was involved in bone marrow transplantation when I was at the City of Hope years ago, and it's come such a long way in the past decade. Generally, the majority of patients who undergo the transplants are individuals who have hematologic malignancies. Years back when we were doing research and trials with breast cancer and other malignancies, there was a promise of prolonging the survival of such individuals and, in fact, cure. Unfortunately, that never panned out.
I know, but is there, if you're told you're going to need a bone marrow transplant, what is the survival rate gone sky high from that, or is it still tough?
Well, it depends on the malignancy. For example, acute myelogenous leukemia is, if you have poor cytogenetic features or prognostic indicators, when you compare the standard conventional chemotherapy versus bone marrow transplant, we're looking at a huge gap in terms of survival in these individuals. A good percentage will go on to become cured. The ones that have the fair cytogenetic findings, who are young, who have a good match, potentially for up to about 60 to 70% of those sometimes can be cured. Chronic myelogenous leukemia is in that same category of cure. However, there's new oral agents that have come a long way, and which has decreased the number of transplants. So we're seeing newer technologic breakthrough agents where transplants hopefully one day may be a thing of the past. So.
Is it hard, by the way, if I need a transplant, bone marrow transplant?
Yes.
Is there a large universe to choose from now, or a very limited universe?
Well, it depends on your ethnic background. The bone marrow registry right now in this country has increased significantly over the past decade. If you're a Caucasian, there's a large pool of potential donors out there. If you're in a smaller sect, such as Hispanics, where we have a very small pool, unfortunately, for donors, the Asian population, etc., and you might be limited.
Got it. Well, thanks for joining us, Dr. Boris Bagdasarian from Glendale Adventist. You want more information, we'll link to his site.
Thank you
from our site as usual. And thanks. Congratulations, by the way, for all the work you're doing in City of Hope and here. And he graduated magna cum laude. Your mom must be throwing that around for the rest of her life.
Thank you very much.
Oh, you're very welcome for taking your time to be with us.
Thanks for the time.
All right, this is The Medical Show with Dr. David Kipper and Peter Tilden. Taking more of your calls next, 800-222-KABC. That's 800-222-KABC, and talking about medical issues,